There is a talk coming up about robotics, but we're going to basically somewhat condense it into this, obviously for the interest of time and actually stay on time for the first time ever. I'm sure John would be very proud of us. So with robotics again, so personally, I'm going to give you my experiences. Obviously, I know this is a tech talk, but I want to really give you some of my experiences with this and how I use it in my practice today. So obviously everything with robotics, and whether you guys use it or not, but basically everybody thinks it's obviously just screw placement, and really it's evolving. We're really seeing more robotic guided with graph delivery. You're starting to see drills starting to pop up from all these companies. Personally, I use the Mazor, use it basically every day in my practice. Obviously the fixation aspect, as we mentioned with the screw placement, and now we're starting to see implant designs being able to work with the robotics to end up placing these devices. Bone removal, as we talked about with facet, they call it facet decortication. Personally, I'm using it to basically remove SAP or IAP, and I kind of plan that out with my procedures now. You're able to convert basically over and using freehand with the Midas Rex after without having to do another intraoperative CT scan. You're able to just convert strictly right over with just a snapshot. And then what we're starting to see now is basically the realignment. So what this is, and we'll get deeper into this, is basically this is out since 2014 with pre-made rods. So let's see here. Okay, so I thought this slide was kind of interesting, and the future is really built on the past. Well, obviously my dad had an experience with the Renaissance, or the green beer can, as some people would call it. So it's kind of interesting that obviously I'm carrying it over, and we're continuing to do that, and I've used basically 2 systems past that now, which he never really even got involved with the Mazor on the second system, I guess we want to call it. This is just a case, looking at it from a navigational standpoint, obviously much more accurate. You know, personally, I use navigation since 2012, right when I started residency, so that was in my hand from day one, and I know I've said that here before, but I'm not saying this is right or wrong, but it was in my hand at day one. I feel like I'm faster than anybody else with a fluoro, and I'm faster with fluoroscopy. Can I do fluoroscopy if need be? Yeah. Is it going to be slower? Of course, because I use navigation daily, and it's part of my practice daily, so you're going to get faster, right? Technology is not necessarily a bad thing, right? I think we could all use thrombin with gel foam like my old neurosurgeons used to make me use, but FlowSeal came out, and we started using FlowSeal, and that seemed to work a lot better and faster surgeries, so why not keep obviously continuing that going with obviously spinal implants and so on. So just quick history, mostly everybody in here knows this. Obviously we had the old Peach O-arm, and then slowly as time's gone on, we S7 and S8. But you're starting to see all 3 of these basically technologies starting to come together, right? So you have the navigation with the Stealth, then you have obviously the history with the Mazor. There's your green beer can, and slowly, and now we're starting to use it with navigation, getting away from K-wire systems. You can still use a K-wire, but basically they're slowly kind of doing away with that, it seems like, as more and more robots are coming out also. And this is the next step, which basically is your patient-specific rods. This was acquired basically a few years back, and I've started, in full disclosure, I started using this about, I want to say 1 to 2 months ago. I've started off small and slowly incorporating it into bigger cases, into more thoracolumbar cases. And it's been pretty successful. And what's really nice is being able to do this basically all on your phone. It ends up getting delivered. Somebody's already done the measurements and then came up with 3 different plans, including interbodies, and that's already sent to you. Let's keep going here. So with robotics, so obviously you have the predictability of planning. You're able to plan basically all your pedicle screws, have all these things laid out. It's going to save you a significant amount of time in the OR. Yes, there is a step process, obviously, with the registration process that can take time, but overall, I think once you get the flow in the OR, you can be faster. I promise you that. The precision obviously is significantly better. You're getting rid of, if you're using the O-arm now and you're just using navigation, you're still bringing your head up, you're still moving your hand around, you're taking that out of your hand, you're putting it obviously in the robotic technology. This was something that I really took to in residency, and I've basically carried it through, and that's why I kind of went with Mazor when I was thinking about doing robotics, is because I had a lot of success in residency and keep going now. And so as we talked about with basically personalized to you, you have these unit-specific rods that are already made. They get sent to you. I think they're down to, I want to say 7 days now. They can get you basically your own rod. But it's also planning where, basically, if you're doing minimally invasive, you're planning where your incisions are, you're planning where your tulip heads are, and the rods usually, what I like about it the most is that, you know, if you already have that rod planned out and you already basically know the correction you want to get, if you lay that rod down and it's not laying in there pretty easily, you probably need to do more, whether it's posterior column osteotomy or so on, to try to get that lordosis and get your sagittal balance correct. And I think that's, especially they're seeing it more with cervical, where you're doing basically a long posterior cervical construct. You know, you already had your measurements, you have a pre-made rod. And a lot of guys will undo the head and slowly bring them up, obviously, and some of these people will end up getting overcorrected. But I think that rod kind of gives you a template right off the bat, and you basically can lay the rod down and know that you already have the correction that you need, or if you need to do more. Try to work through some of this. Some of it's a little redundant. How do I back up here? It's all right. So as you can see, basically, if you haven't played with it, they have both. There's two robotic platforms that are obviously over there, and you can play with and see if it's something that you're obviously interested in. So what makes basically the Mazor unique? So you have, as we said, construct design, registration, innovation, and then the technology such as the drill there. So with the drill, I think it's extremely beneficial, especially when you're doing big redo cases and you're trying to work around basically a big laminectomy or laminotomy defect. I think that can be significantly beneficial. They now have scope eye, which is basically, it's basically a screen that's basically just right up here, and you don't have to keep lifting your eyes up. You can keep working with your navigated drill and not have to keep lifting your eyes up, which is kind of a pain sometimes. So as we said, with construct design, this is just a little video just showing you kind of, and basically you can plan kind of where your tulip heads lay. You can plan your interbody grafts of where they lay and the correction you can predict prior to surgery. What they're showing there is basically the decortication process. They call it decortication. I use it to basically knock off. I'll plan multiple trajectories right there, knocking off SAP and IAP, and I'll have probably 3 or 4 different drill spots and just work through that, and it almost creates a big eggshell where you can just break off the joint pretty quickly and keep working fast. So this is kind of the flow of it for the unit rod. So preoperatively, they get your imaging, then it gets sent basically to your phone, and there's 3 different plans laid out. They've picked the interbodies, obviously, to try to get your sagittal balance corrected. And then as time goes on, it will start to predict kind of how much correction, how close you're getting, basically. And then the rod actually will come out, start with basically your parameters that you're correcting, and it kind of figure out kind of your trend over time, which is really nice. Let's see, as we mentioned that, so I'm just going to work through these. So with robotic guidance, just quickly, you can do scan and plan, which is the intraoperative CT scan. Personally, I don't like this as much. I think it creates a little bit bulky workflow in the OR, because then you kind of have to stop with the patient on the table. You have to plan your screws and then keep going. Personally, I do CT to fluoro on all my patients. So preoperative CT at 1 millimeter cuts. All these screws are already planned, laid out. Back table already has them laid out, and once you do that, your workflow in the OR is much better. It's just basically a segmentation image of each vertebral body is obviously broken down. It doesn't matter if you've done an interbody or not. You can still use it because it's all broken down per 1 vertebral body each level. Let's see if this is going to show it. So this is a little image of the decortication process. You can see basically the navigated drill after. What which is really nice because you don't have to obviously re-register or redo another intraoperative CT scan. You basically do one snapshot. When I mean a snapshot, don't mean like a fluoroscopy image. It's basically, I call it a gingerbread, but you do that and then you can basically keep using freehand navigated products, whether it's a gear shift or whether it's, a navigated drill. Keep going back to that image, I'm not sure. So this is one thing that changed fairly recent. Basically, you can see with the standard drill, initially when we were doing these and doing them with K-wire, they had a skive potential with how that drill was. With how it is now, you can see basically much significant. I haven't skived on in a very long time since I've started using that drill versus the old drill. The old drill, you had to be very careful, especially if you had a bad facet arthropathy or something like that you were docking on. Again, as mentioned, basically you can plan obviously all your implants. These are obviously with Medtronic implants, and plan where your T-lift graft and how anteriorly. Obviously you want it as anterior as possible, but you can see and predict how much you are actually correcting. Just a little video there of that. That's actually an image of the drill in the decortication process. And so they only plan one this, and then the video on the other side is basically delivering bone graft. Where I find this to be beneficial would be a case that basically if you're doing like a perc fusion for a burst fracture, and I just kind of remember my dad always saying, do perc fusions actually fuse posterior laterally? Yeah, I think some of us have put bone down there. Does it actually fuse? Probably not. I think this is a much better option, especially for that, and being able to basically decorticate right there and then end up delivering bone graft successfully. So obviously you can look at basically the entire picture, from planning standpoint with the unit rod. You now have facet decortication, all the data collection that's occurring with these unit rods. I think as they continue to collect that, we'll be able to predict that better. I usually, when I get my unit rod, especially if I'm doing even a lumbar case, I'll actually have them make it just a little longer. I'll make it even like it was a T10 to pelvis, and then I'll just end up cutting it back. But they can basically do whatever you want to do from that standpoint. Thank you.